To help maintain promote growth of leiomyoma, the vessels create a local hyperestrogenic environment. Also, some conditions provide constant estrogen exposure that encourage leiomyoma growth. Example: early menarche and obesity, polycystic ovarian syndrome. Despite this hormonal response, myoma formation is not induced by combination of OCP, deportment oxy. This myeloma is composed of blend of spindles, smooth muscles, elongated blunt ended nucleate apoptosis and finish. The cells are arranged interlacing fascicle that intersect right angle. The interface between leiomyoma and adjacent myoma can be grossly. For myoma development, race, age are notable factor. Myoma rare in adolescents, but rate rise with age during the reproductive. In one study, community incidence 70% weight over. This classification numerically based on the location subserous myoma and leiomyoma original from the myocyte adjacent to uterine serous as variant parasitic leiomyoma which themselves to nearby pelvic structure from which the vascular system this myoma then may not detach from the patient parent intramural leiomyoma those growth enter within the internal wall proximal to the intramural growth toward the walls to the intramural cavity last pedunculated leiomyoma attached only by stalk to their procentral myoma type 07 are examples of pedunculated 50%, more than 50%, less than 50% intramural, more than 50% intramural, 100% intramural touching the endometrium. 4 is intramural, 5 is subserous, more than 50% is intramural, less than 50% is intramural, 6 subserous pedunculated, 7 other cervical and parasitic fibroid. The ecosystem type 3, although comparatively intramural is now considered to overlap with this submucous because it contact with the endometrium nodes. Type 8 defines that don't related to the myoma include cervical, broadly covered or parasitic transmural lesion. Example 2 to 5 categorize both the endometrial and serosal component. In this case, the endometrial surface is described first. In preglioma developing cervix broadly covered in the developmental. Most women with glioma is symptomatic. However, affected women may complain of bleeding, pain, pressure, infertility. If this bleeding is common, especially heavy menstrual bleeding, despite this underlying pathology is called vasodilation of the endometrial vessels alter hemostasis as suspected by the vasodilation of the endometrial vessel. The vasodilation. Vasodilation of endometrial vessel and alter hemostasis. In general, symptom risk rise with myoma size and number. Pressure and pain. Sufficiently large uterus can cause chronic pressure. Urinary frequency, incontinence, constipation. Aside from pressure, patient may also note chronic dyspareunia, and non-cyclical pelvic pain. Acute pelvic pain is less frequent complaint, but is most often seen with degenerative prolapsing or twisting leiomyoma. Acute pelvic pain is less frequent complaint, but most often degenerating prolapsing or twisting leiomyoma. With leiomyoma, degenerative prolapsing, twisting. Degeneration, prolapse, torsion. With leiomyoma, degeneration tissue necrosis classically causes acute pain, fever, leukocytosis. This constellation mimic other acute pelvic pain source. The sonography typically performed to help identify a cause. Usually non-descript leiomyoma is computed. CT may help explore other etiology to or clarify pelvic anatomy obscured by multiple large leiomyoma. Treatment of myoma degeneration can non-surgical include non-steroidal NSAIDs. Additional analgesic antipyretic needed. If differentiation between myoma degeneration and acute endomyomatritis include broad spectrum antibiotic administered. In most cases, symptoms improve within 24 to 48 hours. Also, the stalk of large pedunculated myoma can acutely twist to cause similar ischemia and pain. In this case, surgical avoiding the stalk of myoma is curative. Prolapse of a pedunculated tumor of the endometrial cavity can cause marked cramping and pain as the tumor stretches the endocervical canal pass through it. Associated with bleeding or serositis is common. Rarely cervical stretching may prompt a vaginal response. Vagal response prolapse can lead to uterine inversion with a myoma prolapse. Visual inspection, visual diagnostic. However, sonography is often performed to evaluate the size and number of the uterine Explore the source of surgical treatment, but severely limit stop is described. Depends partly, but only 1 to 3% in particular case due to rarely to leiomyoma. Instead, subpartly is more closely associated with mucosal leiomyoma than tumor located elsewhere. Improved pregnancy following hysteroscopy resection had provided the most of the indirect evidence of this link. Evidence does not implicate subserosal tumor for intramural tumor that don't disturb the endometrial cavity. The relation with subpartly is more tenuous. Evidence benefit from myomectomy is conflicting. Importantly, the strength this evidence must be weighted against the morbid associated myomectomy. Peritubal intrauterine lesions can threaten infertility. Myometrial defect leads to risk of uterine rupture during subsequent pregnancy. Peritubal intrauterine lesion. If surgery is elected, conception attempt ideally follow complete surgical healing. If possible, to limit tumor recurrence. Both the uterine leiomyoma spontaneous miscarriage are common. An association between is not based on conclusion. Moreover, there is no conclusion with the surgical treatment reduce miscarriage rate. The leiomyoma upon return to pelvic examination with the finding of uterine enlargement, irregular contours both in reproductive age women, urine serum beta SSG level, absolute pregnancy sonography done to reveal pelvic anatomy of moderate TBS provided superior resolution, but some so last transappearance means the entire corpus leiomyoma appears focal mass of heterogeneous secret texture. This varies from hyperechoic depending on the ratio of the smooth muscle to connective tissue, the presence of degenerative substances, calcification appear hyperechoic, remove the tumor randomly scattered throughout the mass, cystic mixed lesions typically darts the leiomyoma with multiple smooth walled irregularly sized but generally smooth anechoic area. The endometrial cavity also inspected for mucosal myoma, endometrial leiomyoma, endometrial polyposis anechoic with this focal transmission subserosal leiomyoma classically sonograph caliper placed outer border to outer border during myoma measurement lesion. The endometrium can appear thick irregular during the TBS. Adjunct imaging tool may help clarify anatomy of the saline infusion sonography or hysteroscopy often be provided additional cavity information, although 3D TBS or 3D SIs be able to define the cavity. Leiomyoma have the characteristic vascular pattern. This can be identified color Doppler by power Doppler. Color Doppler or power Doppler technique. Peripheral circumferential removascularity. Peripheral circumferential removascularity from which a few basal iris to penetrate into the center of the tumor is classic finding. Peripheral vascularity, few basal iris penetrate into the center. Adenomysis usually so central rather than periphery vascularity. Polyps classically so pedar basals. As such, Doppler image can help to differentiate these. Fibroid adenomyosis polyp, pedar basal, central vascularity, peripheral. For the infertile women, endometrial cavity can be evaluated HSG hysterosalpingography. The first two are for tubal patency. Submucosal fibroid clearly outlined during saline infusion sonography. This size catheter pattern is seen in the lower uterine cavity. The 3D ultrasound sonography surface leiomyoma. The hysteroscopy photograph of submucosal leiomyoma. MRI imaging may record when imaging limited by body habitus distal anatomy. On T2 image myoma usually dark homogeneous circumscribed notable area of danger created variation of this typical appearance. MRI imaging allow more accurate assessment of the size number location that can help to identify the appropriate candidate for hysterectomy or not. Alternatives such as uterine embolization myomectomy of note for dominant fundal uterine mass. MRI imaging can also differentiate the fundal myoma which is suitable myomectomy indication from a compact collection adenomyosis. Another mimicker is leiomyosarcoma, which is often single large mass with the cystic degeneration. MRI imaging provides greater but not perfect accuracy for diagnosis of LMS. CT is not widely used for the categorization of myoma. However, as described earlier, it may additional initial diagnosis patient with acute pain and clear etiology. Observation non-surgical management. Leiomyoma is generally slow growing, thus regardless of the size, asymptomatic leiomyoma usually can be observed with annual pelvic examination. At time, adnexal assessment may be hindered by large irregular uterus, patient obesity. Some adenoids, in contrast, symptomatic leiomyoma can be treated with long-term medical therapy. Discussed in the next video. Other medical therapies use certain priority agent. Tumor typically regress postmenopausally also because this tumor includes some women choose medical treatment to relieve symptom reach to menopause. Either combined oral contraceptive to continue oral progesterone DMP can be used to induce endometrial atrophy. Endometrial atrophy and decreased prostaglandin production. Despite the frequent practice, few studies have revealed this specifically for leiomyoma related bleeding. Their use expected effect of extrapolated from study in non-myomatic. Also, small study LNGIS significantly improved the leiomyoma related bleeding term. However, for women, the myoma LNGIS exposure rate higher, range from 10 to 15%. 10 to 15%. Candidates should meet criteria listed. Tumor that distort the endocrine preclude the TLNG placement into the larger cavity. Also, the device is string migrated separate to make it, although not a strict clinical limit. Many studies have included only uterine measurements less than 12 week size. Other sex steroid hormone options include androgen, danazol, gestrin, which reduce volume, improve bleeding symptom. Another their prominent side which include acne, research include the rostinine agent. GNS receptor agonist agent synthetic derived gonadotropin GNS function GNS receptor either agonist or antagonist with a different action at receptor. Both group ultimately inside compound systemic drop in estrogen and progesterone level. GNS agonist is inactive taken orally. If taken about other preparation available the leuprolide acetate is poor. Indication of the medical treatment of uterine symptom dysmenorrhea patient if available Europe. If dysmenorrhea is present in acid combined oral contraceptive DMP and LNG GNS agonist or ileoprostatical menorrhagia combined oral contraceptive pill DMP can use pelvic pressure symptom GNS agonist and LPSTL infertility because this reduce the size GNS agonist infertility. Drug administration FDA approved leiomyoma treatment table 3.75 mg monthly dose or 11.25 3-month intramuscular dose or 11.3 3-month intramuscular dose. Less frequently used GNS agonists include goserelin administered as 3.6 mg monthly or 10.8 mg. Goserelin 3.6 mg 3.6 IM 3 months after depot implant. Triptorelin 3.75 mg, naparelin 200 microgram twice daily nasal spray. Naparelin 200 microgram nasal spray. This later they are not effective for leiomyoma treatment. These later available is they are effective. GNS agonists shrink leiomyoma but by targeting the growth effect of estrogen progesterone. Initially, these agonists stimulate receptor pituitary gonadotropin. GNS agonists shrink leiomyoma by targeting the growth effect of estrogen progesterone. The GNS agonist shrink leiomyoma by targeting growth effect of estrogen progesterone. These agonists stimulate the receptor on pituitary gonadotropin to cause suppression the release of both LH and FSH, also called a flare. Initially, causes a supraphysiological release, then also called a flare. This is last 1 week. Supraphysiological and supraphysiological flare. Flare last for 1 week. While the long-term action, however, agonists downregulate GNS receptor in gonadotropin with their long-term action. Downregulate the gonadotropin receptor desensitize the gonadotropin for the GNS stimulation. Subsequently, lower gonadotropin secretion lead to suppressed estrogen level 1 to 2 weeks after the initial GNS agonist. Result of GNS agonist treatment include dramatic decrease in uterine leiomyoma volume. Decrease volume. Most women experience a mean decline volume of 35 to 50%. Most of this occur during first 3 months of the therapy. 35 to 50%. As a result, smaller uterine size may also less complicated extensive surgical procedure. Clinical benefit of GNS agonists include pain relief and immense emotional bleeding, amenorrhea, for example, 90 to 70 women achieve bleeding control by 3 months, 90 to 97%. This pair is hypoepic. The endometrial cavity. Leiomyoma has characteristic vascular pattern. This can end up close. Significant cost study paid more myriad those many positively up to 95%. Significant result 6 point loss of trabecular, but not all of which been recovered following discontinued as a result. This is essentially not a good loss without addback therapy. To obviate side effect, addback therapy counter hypoestrogen symptom without negative shrinking action. This made possible by the estrogen level required to improve vasomotor to minimize bone loss is below the estrogen threshold. Addback therapy is typically begin 1 to 3 months following GnRH agonist. Regimen includes estrogen combined with progesterone. Those studied generally low dose preparation equivalent to an HRG. Such as norepinephrine methoxyprogesterone has a role as addback therapy have yielded contraindicated results. Last, although usually less of an addback therapy with selective estrogen modulator has tubular relaxation prevent bone loss. GnRH antagonists, elagolizumab, lugolizumab, non-peptide pump suitable oral use, although not approved. As one advantage, the initial player of gonadotropin is abated, as one initial player of gonadotropin fundamentally both menstrual bleed and the myoma volume decline. As expected with GnRH suppression, the hot flashes permanent side effect. However, addback therapy attend both hot flash severity pulmonary disease lasts during 6 months of treatment. SPRM has not progesterone is essential for myoma growth. Thus, antagonist is another option. Agents are classified anti-progesterone if they are universal prompt antagonist effect upon binding to the progesterone. However, agent termed selective progesterone if they exert anti-progesterone effect some tissue but progesterone effect in other. Ulipristal is the SPRM currently marketed in the United States in emergency contraceptive for myoma treatment. Ulipristal available in Europe, Canada. 5 mg orally daily dose for up to 12 weeks. UPA act as a potent anti-progesterone myoma shrink their volume. UPA perform compared with lipoyl acetate to shrink myoma volume control heavy menstrual bleeding. But unlike GnRH receptor agent, it avoids the gonadotropin played hypoestrogenic side effect. Estradiol level lie in the mid-molecular range. The effect of ulipristal in the myometry is not that pure antagonist. Estrogen required endometrial change recognize elevation of the progesterone receptor modulated associated endometrial changes. Replete dysynchronous growth between gland and stroma. Progesterone associated endometrial progesterone receptor modulator associated endometrial changes not linked to short-term higher rate of endometrial hyperplasia or cancer. And in the largest randomized study, progesterone associated progesterone receptor modulator associated endometrial changes within 3 to 6 months following during drug cessation. However, the long-term effect are unclear. This is the main reason to each treatment course limited to 12 weeks. This had repeated course therapy has been evaluated. More recently, concerns have arisen regarding the liver injury. Underlying liver disease now contraindication. The European Medical Agency still permit on 12-week course preoperatively. Additional course allowed only those who are not eligible for surgery. Serum liver functions testing is done pre-treatment then monthly. First 12 weeks course, finally 2 to 4 weeks post treatment. Monthly during the first 12 weeks course. First 2 months monthly. Then monthly during the first 2 to 12 weeks course. 2 to 4 weeks. Enzyme level they more times from situation. Serial presentation of treatment monthly during the first 12 weeks course. Non-hormonal options. The tranexamic acid. Tranexamic acid antifibrillary agent described fully chapter study. Specifically, myoma-related subgroup analysis does not provide some support for its use for this indication. The benefit of NSAID for leiomyoma-related bleeding care lies unclear. Study have concluded thus, although NSAID are potentially helpful for myoma-related dysmenorrhea, available data not robust support. The enzymatic aromatase convert androgen, estrogen, and inactive. In myoma, aromatase contribute to the estrogen that pulls sustain within premenopausal inhibition. Aromatase appear to be predominantly suppress estrogen production. Myoma might only partially suppress the activity of ovary aromatase inhibitor. Aromatase inhibitor side effects include hot flashes, nausea, musculoskeletal, motor, and can augment FSH release, can risk of pregnancy, formation of multiple cysts, long-term bone cardiovascular health unclear. Urinary embolization is an angiography procedure that delivers synthetic particulate emboli into both uterine blood flow, thereby restricting production of ischemia necrosis because vessels serving leiomyoma have a larger caliber. This microsphere represents directed to the tumor sparing surrounding myometrium. This microsphere represents directed to the tumor sparing surrounding myometrium. During uterine angiography, catheter place one femoral artery advance on the fluid and sequential catheter both uterine failure to embolize both uterine allows collateral circulation due to sustained failure to leiomyoma blood process. There is significant low success rate with management option for women who might otherwise consider hysterectomy myomectomy. Based on current evidence, women who have not completed childbearing may be better served by myomectomy. Other patient limitation, many areas altered vascular enterprise genes is thought to be narrow vessel. Peduncular submucosal tumor less suitable. This tumor can infect and slop. The peduncular submucosal tumor less suitable. This tumor can infect and slop. Peduncular submucosal tumor previously excluded, but the society interested this prior to uterine also women undergo radiological consultation and MRI imaging assessment quality for success. The gynecological infection and endometrial cervical cancer. Deeper uterine intrauterine. Following uterine embolization, pain management usually requires 20 to 40 hours admission. After discharge, most patients have pain control with NSAID have a rapid return to daily activity. However, as a result, leiomyoma necrosis patient can develop post-embolization that may require readmission. These symptoms are seen in 10 to 25% cases. The last 2 to 7 classical pelvic pain, nausea, low-grade fever, liquid management supportive analgesia, antibiotic not required, but may be infection and alternate diagnosis. Absolute relative contraindication, pregnancy, active uterine and adnexal infection, suspected reproductive tract malignancy, infections, pregnancy, malignancy. Relative contraindication like coagulopathy, renal impairment, severe contrast, desire for future partly uterine size 20 to 24 weeks, prior salpingectomy, oophorectomy, prior pelvic radiation, large hydrosalpingic GNS agonist region, coagulopathy, bleeding complication, renal effect and contrast, severe contrast, desire for uterine size difficult to embolize, prior salpingectomy more than 20 infection, malignancy, pregnancy, prior salping, alter aerial anatomy, alter large adrenal increase infection risk, GNS agonist. Unless bleeding and bulk relief is not immediate, but by 6 months clinical response are significant. Several trials have shown high rate of patient symptom improvement. Compare with hysterectomy, uterine embolization, shorter hospitalization, reduced poronty pain score. Earlier return to daily activity, uterine embolization also compare favorably with myomectomy for symptom removal. However, long-term surveillance reveals 20 to 30% will require subsequent procedure, which many cases hysterectomy. Comparing surgery, uterine is comparable major complication rate but higher minor complication rate of leiomyoma. Leiomyoma tissue passes is common, seen approximately 4% of cases. Necrotic leiomyoma that pass into the vagina usually can be removed in office, thus retained in the uterine cavity. Family attached to the uterine wall require dilatation, evacuation, growing hematoma, prolonged vaginal discharge, other frequent complication. People are minor as the transiently elevated PSA level may last few menstrual cycles after uterine embolization, permanent amenorrhea. However, develop occasionally, more often in older reproduction. This likely is concurrent embolization of the ovary. Pregnancy subsequent to uterine can pose complication, although the number of aborted pregnancies is more consistent. The problem high rate miscarriage. Uterine typically low major complication rate, high symptom symptom. MR guided focus ultrasound energy focus to heat inside coagulating necrosis related by concurrent MR imaging enable this energy to precisely targeted, also provide real-time tissue temperature feedback to limit surrounding tissue injury. After treatment, gradually enhance MR image to obtain measure the imaging coil, MRI unit, myoma, focus ultrasound energy, ultrasound transform, non-perfused volume. MR images are obtained to measure the non-perfuse volume within treatment by the correlate positive with tumor and symptom. Also, MR guided IITS because only conscious sedation as with rapid recovery season lasts 2 to 3 hours, during which patient lies prone with MR imaging unit. The blood is continuously drained for potential contraindication of pregnancy, uterine malignancy, in menopause, calcified myoma, general contraindication to MR imaging. Obstruction along the energy path. This latter include abdominal wall, scar, bowel, foreign body. Study other exclusive and concrete will be in case of uterine size more than 24 weeks, myoma more than 10 cm, myoma lying deeper than 12 cm of the skin surface. More than 24 week size, more than 10 centimeter, than 12 centimeter from skin. Also failure rate, injury rate greater in pedunculated subserous submucosal myoma. Concurrent adenomyosis tumor need vital structure more than 4 myoma or more than 4 myoma. Peduncular serous submucosal myoma concurrent vital structure because this limitation may never ineligible. Early prospective studies show that MR quality of life score will develop potential minor complete vaginal discharge, fever, hematuria, abdominal edema. More serious condition venous thromboembolism, necrotic myoma, tissue retaining in the uterine cavity, uterine bleeding, endometritis, ball. MR accelerator device now permissible for women who desire fertility preservation. In one review of 102 pregnancy following imaging, total level live birth 38% antibodies, 44% placenta, 55% requirement placenta. Placenta accreta and uterine rupture is not noted. Comparing uterine embolization emergency, the fast randomized trial 30% re-intervention rate within 3 hours after emergency, 30% re-intervention. Other efficacy data from non-randomized cohort, improvement in symptom score in 30 to 70%, but similar to EVE, symptom relief with it at more than 12 months following 30 to 24% alternative procedure for the symptom, including hysterectomy. 13 to 24% require. Comparative is one small study is successful preventing symptom but 5 to 16 electoral intervention. As an alternative, American new modality is imaging focus ultrasound energy but not yet FDA approved. Ultrasound guided focus ultrasound does not provide thermal feedback. The limited data regarding efficacy safety concerns. It can be vaginally abdominal laparoscopically. Following hysterectomy, post-operative satisfaction rates are high. Data shows superior rate compared with conservative. This uterus preserving surgery exercise by MS. Uterus preserving surgery exercise myoma is considered for women who desire fertility who decline. Contraindication active infection, pregnancy, suspected malignancy. Compared with hysterectomy, myoma possesses high risk of myoma recurrence, incarnate symptom but has lower rate of injury to adjacent organ, blood loss, surgery length, febrile morbidity. Myomectomy can be performed to up to 16 week size. Myomectomy can be performed hysteroscopically, laparoscopically by laparotomy. This illustrated in the atlas proportion. This predominantly intercavitary resection history whereas subserous intervention recur. Subserous intervention with laparotomy, laparoscopy, surgical action for intercavitary hysteroscopy section upper quick recovery less surgical mobility hysterectomy. Hysteroscopy myomectomy positively correlates percentage of exercise volume. Size, topographic penetration criteria can guide the patient selection. This section is most effective type 011. Those measuring less than 3 cm, although suitable more skilled surgeon. Larger type 2 carry high risk of incomplete resection, difficult visualization, preparation, reaching their volume limit. For hysteroscopy, generally 15 to 20 restricted with additional surgery. In contrast, women subserosal fibroid intervention are most independent tumor buried in the muscular internal, then reconstruction normal anatomy. Also, surgical complexity subsequent risk increase. Step W classification criteria is to size, topography, base width, size 0, 1, 2, less than 2 cm, less than 2 cm, 2 to 5 cm, more than 5 cm, topography, low, upper, middle, lower, low, middle, upper. Base is less than 1/3, more than 1/3 to 2/3, more than 2/3. Penetration more than less 0, less than 50%, more than 50%, lateral, equivalent lateral, then +1. Point also 0 to 4 is group 1, 5 to 6 group 2, 7 to 9 group 3. Surgical difficulty decreases point total rise. Worms adapted from worms taker, step W classification, last per. Type M usually improve pain bleeding. For example, heavy menstrual bleeding improve approximately 7 to 10, 70% patient re-intervention 10 to 15%. In selecting a surgical approach for subserosal intramural fibroid, several factors are weighed: laparoscopy, leiomyoma resection, yield successful outcome, advantageously shorter hospital stay, less febrile mobility, blood loss, adhesion formation, pain found with the laparoscopic resection, however, rupture subsequent pregnancy, although rare, has a higher rate of occurring laparoscopic location. Single layer closure, thermal myometrial injury from git-related surgery, which proper patient selection criteria by surgeon for laparoscopy approach limit can include larger myoma more than 6 to 10 cm, tumor more than 3 locations that require multiple incision. General larger internal require laparoscopy scale. To overcome some of these limits, many laparotomy techniques may be elected, however, similar to larger laparotomy incisions. Many laparotomy is faster but still undergo laparoscopy. Robots overall, these offer similar minimal invasive surgery advantage but no longer. Moreover, due to poor tactile feedback, robotic instrument in some several endometrial destructive modality are elected abnormality due to endometrial dysfunction. This can also use a rare technique for myometrial bring data. Whether the fail, however, if treating submission imaging less than how this specific tumor was utilized to discovery section. Myelitis is a procedure using tool directly control the myoma inside myoma in a substance in case with the various procedure radiofrequency energy vaporization. Radiofrequency applies to women with myoma less than 7 cm size. Myoma less than 7, less than 16 weeks. Exclusion criteria for study included myoma more than 10 cm, type 0/1 myoma, pregnancy, infection, suspected malignancy. A desired future fertility is not contraindication. Data on pregnancy outcome for few encouraged with the new approach. Early evidence show 50% improvement in symptom severity of score or one in study intervention. Different from myelin laparoscopic occlusion. Attempt to achieve myomanic surgical sealing both the body. Most myelin data have uncommon tumor complication of affection numerous. Rare manifest. Most myelin treated as just described. Uncommon complications can also have numerous other organ deep vein thromboembolism risk increase in those with myeloma weight more than 1000 gram. Deep vein thromboembolism more than 1000 gram. Uncommon neurologic complication, acute urinary retention from compression by myeloma, brain incarcerated myeloma, situation management, bladder drainage, polyps catheter, intermittent self catheterization, temporary condition. In contrast, severe hydronephrosis, ureteral compression, usually pelvic grim, both retention, ureteral reconstruction and ureteral removal. In case of myeloma, also myeloma syndrome can create elevated red blood, but not the pancytosis. Also, rarely myomatosis, erythrocytosis in create an elevated red blood cell count, but not the pancytosis. Intravenous leiomyomatosis in bed extend serpiginiously into the uterine vena cava, even cardiac chamber. Multidisciplinary surgical hysterectomy and extended preferred treatment. Benign metastatic leiomyoma derived from morphological benign uterine leioma that disseminated hematologically. Slow growing lesion found most often in the lungs. Answer diagnosis excision of symptom. Excessive lesion is multiple masses, permanent lesions are by assimilated causative surgery. Disseminated peritoneal leiomatosis appears as a numerous small peritoneal nodule of abdominal cavity. Widespread peritoneal metastasis (EPL) is usually found in women with reproductive age often associated with pregnancy. Conservative surgery performed diagnosis the treatment typically excision of exogenous hormone anti-estrogen agent from primary breast. Electromechanism also during multiple small peritoneal leioma may be found later for the primary secondary implants of implant. This is outflow obstruction.